Hey, Lily, thank you for, I've been enjoying my mask, Lily.
Oh, good. I'm glad. You
Thank
see
you.
that, Pat?
Yes, I love it. I'm trying to get a bunch. I'm trying to get a bunch of them for my Loyola buddies before Thanksgiving.
I've been meaning to tell you that. I
Oh.
really like it. Libby.
Love it.
Hey, Val.
Hey, Bill. Hi, everyone else. Sorry, didn't want to be selective.
Hi, everybody. Thanks for joining us. We're going to give, if everybody could throw their microphones on mute for the moment, we're going to give some of our other guests that we're expecting another minute or so to join us, and then we'll get started. Okay, well, no time like the present, as they say, right? Well, good afternoon, everybody. Shortly afternoon, 12:01 here on this gloomy day, but it's great to be with everybody. My name's Pat Muth. I am the Director of Major and Lead Gifts here at Catholic Charities, and it is my pleasure to introduce our Executive Director, Bill McCarthy, who will open with a prayer before we introduce our special guest. So, Bill, please.
Thank you, Pat, and good afternoon, everyone. This time of year, I go through kind of a rotation of reflections and prayers. And this is one that Father Ray wrote that's one of my favorites in the visualization of us as greeters and a culture of hospitality that we have at Catholic Charities. God, we call you the Holy One, Hashem, and Allah. All our sacred scriptures tell us repeatedly you are seeking to come into our lives in meaningful and powerful ways. We wish to now welcome you, even as we seek daily to welcome the poor and those in need among us. We are in many ways door people, ever watchful for that next person who comes through the door bearing a need. We know ever so well we will be challenged by that person. We will be challenged to offer ourselves and our services. We will be challenged to find those precious resources that lie nowhere else other than within our own hearts: respect, compassion, understanding, and a particularly powerful form of love. As we welcome those individuals who come through our doors, we also welcome whatever gifts that person brings and will leave for us. Such gifts are often packaged in what looks like what should be set aside or even thrown away because, at first sight, it seems offensive. Yet when we take the risk to look very closely, a skill we continually seek to sharpen, we discover some gift of the human spirit that will empower us in our encounter with the next person who comes to our door. So God, Hashem, Allah, bless us, Catholic Charities, people of the door. Bless us particularly during these challenging times when fear has caused so much closing of doors, even those closing of minds and hearts. Bless our profound commitment to keep opening doors for those who come to us. For through those doors, blessings beyond measure will flow, in and out, today, tomorrow, and always. Amen.
Amen. Thank you, Bill. Greatly appreciate you taking the time to do that for us. With that, I'd like to take this opportunity to welcome our guest speaker for today, Mr. Zachary Richards. A little background on Zachary. Zachary has been a licensed nursing home administrator for the last 10 years with experience working on both coasts, both in California and here in Maryland. Zachary did spend some professional time outside of the nursing home industry building up his finance and business skill set, but according to him, he found it a bit uninspiring and morally unfulfilling. And we're happy for that on our end because now he's with us. Zachary accepted the position at Catholic Charities at St. Elizabeth's Rehabilitation and Nursing Center, because of the reputation of the center and its focus on providing quality care to all of our elder neighbors who reside there. While not at work, Zachary loves being involved in community charitable organizations and really enjoys spending time with his wife and their 4 kids. This has been a unique time at Catholic Charities in this COVID world, particularly in elder care. So we're really grateful to have Zachary here with us today to shed a little bit of light on some of the challenges and some of the successes that we've had over the last few months. So with that, please help me welcome Zachary Richards.
Thank you so much. And Pat, thank you for giving us a spotlight at St. E's to explain everything that we do and how we're part of Charities. Today, I'm just going to walk you guys through how skilled nursing care centers really work, how they fit into the continuum of care in the healthcare industry. We'll speak about COVID, its impacts on us, and then what we're hoping for a post-COVID world. St. Elizabeth's was founded in 1927 by the Daughters of Charity, and we became part of ACC in 1992. So we're coming up to 100 years. We have been on the same campus for the last 100 years, and that building is now part of Jochum. And we are also on the same campus as St. Agnes Hospital, because that was also founded by the Daughters of Charity. We are a 162-bed rehabilitation and skilled nursing center. We have 5 different neighborhoods, and we have a 30-bed memory care unit that focuses on dementia and Alzheimer's. St. Elizabeth is unique because it is a true culture change facility. And what that means, in the early 2000s, there was a big shift to change facilities from institutions to actually places where people would want to live. Before then, it was really people, your breakfast was at 7, lunch was at 12, dinner was at 5. That's it. You get showered on this day. It wasn't a choice-based, it wasn't elder center. We actually call them elders because we are trying to focus on that person and cherish the divine within that person. And when you call someone a resident, if you own an apartment building, that person is a resident or a tenant. It's a different relationship. So at St. Elizabeth, we really are focusing on that person-centered care. Our elders tell us when they want to eat, what they want to eat, when they want to get up, what their care day will look like. Obviously, there is a structure to that, and we can't just, throw our hands aside and say, do whatever you want. But if they, we try to mimic their schedule at home. I know my grandmother every morning would have orange juice, coffee, and a cigarette. These were different times. That was every morning. That was her routine. She had to have that before her day would start, right? We're a smoke-free facility. We don't allow our elders to smoke. But if we walked into that room with a full tray at 7 o'clock in the morning, we would always say, well, this person never eats breakfast. Well, no, because at home, this person ate breakfast at 11 o'clock. So that's something unique about St. Elizabeth's, that we took on a full culture change. We have neighborhood guides, which are elder advocates. And the most unique part about St. Elizabeth is we do not have call bells. We have a pager system, so there's not that constant ding, ding, ding. Next slide, please. So what is a skilled nursing care center? And how does it fit into the national healthcare system? So what most people don't understand is skilled nursing care centers basically run 2 separate business models within one. We run a short-term unit, which focuses on getting people discharged back into the community to age in place. They're really there for physical therapy, occupational therapy, or speech therapy. That's someone who had a knee replacement, had a hip replacement, had a fall at home, was a little disoriented, got sent to the hospital, and we're that step-down level of care for them before they go home. The reimbursement rate is higher for that person. Our rate on average is $542 and change per patient per day. Now, what you have to understand is that is everything we get, and that has to cover all of their services. So it's not just we get that money, we get to put in our pocket. We're paying for that physical therapy, we're paying for that occupational therapy, we're paying for that speech therapy. We're paying for their medications, their labs, their transportations if they have a doctor's appointment, and then we have all the fixed costs of the facility. So on average, what you see out of that $542 is somewhere in the neighborhood between $70 and $90 per patient per day, right? And so we're running this business model. And then on the other side, we're running a long-term care business model. So this is focused on what is referred to in the industry as custodial care. We are helping people age with dignity. We will be there, typically will be their final step before they pass on. We are making sure that they have a decent quality of life and that we're giving them everything we can to make their lives better. Now, a lot of these folks are not so much different than those short-term rehabilitation folks. So it's not just, don't imagine everyone lying in bed in hospice. Those people still need therapy that we're giving to them. We still pay for their medications, their labs, all of that stuff, those ancillary services we're paying for, but the reimbursement rate is only $287 a day. So we have to balance long-term and short-term residents in order to make the care center profitable. Because on average, on our long-term residents, we will lose money. I'll give you an example. We had a resident, long-term resident, had C. diff. The doctor prescribed all the medications, went through the whole process, and then said, I'm really sorry, but nothing else is working. This medication is $4,000 a dose. The resident needs it for a week. We have to eat that cost. So that's $4,000 that we have to take out of that $287 per day and to pay for that. So that's kind of the balance that we're always doing in skilled nursing care centers, is running these two separate operations and providing services. Next slide, please. So this is just kind of an overview of skilled nursing care centers in the United States. There's over 15,000 centers and 1.7 million beds. A lot of people just think nursing homes are where people just, that's it. They play a very diverse role. We employ 1.7 million people in the United States. It's a huge industry, and it is mostly government funded. You can see here on the right, 57% is a Medicaid funding, 14% is Medicare, and then that 29% is private pay, private insurance. That private insurance is really assigned Medicare. So again, that is government funding. So we are acutely aware of the pinch of government reimbursement rates, and we will have to see post-COVID what those rates look like. Next slide, please. So the next aspect of running a skilled care center is regulation and punitive enforcement, what I call punitive enforcement, but it is enforcement. A brief history is healthcare regulations came out of the need and experiences of state-run institutions like Rosewood or other facilities like that, that historically everyone has a very terrible image of, and we all know that they just kind of ran. A lot of them were understaffed, and historically the state said, here's a person, take care of them, and that was it. So whatever happened, and we know that all those state-run institutions have closed, and for good reason. But the view of regulators comes from that, is that you always will be doing something wrong. There's a guilty until innocent view when it comes to care centers. On the left-hand side, this is the scope and severity tool that surveyors use when they walk into our facility to grade us. A, B, and C, it's a pattern. It goes all the way up to L. I've never heard of a facility getting an L or a K. Typically, those facilities would go into a process of decertification. But you can see the A, which is the lowest level, is the potential for no more than minimal harm. So even if there's no harm, it doesn't affect anybody. The viewpoint is that there's a potential for no more than minimal harm, that you're always going to cause minimal harm no matter what you do. We had a COVID survey where we had a goggle policy. The aide was scraping dishes, no residents, no elders near them, no other staff member. It was just scraping dishes from lunch, wore her goggles up like this. The state surveyor walked in and said, now what's your policy? So at the time, our policy was stricter than the CDC guidelines, and we required staff to wear goggles at all times. That was our policy, the wording of our policy. Now, we obviously didn't mean for someone scraping dishes or they had to scratch their eyes having to wear their goggles. But the surveyor came in and said, well, that's your policy, even though CDC says only when you're providing care, and that's the state guidelines as well, we're still going to give you an aid deficiency. So we received a deficiency. Again, no harm done, a lowest level, but we were stricter than CDC guidelines. So what we did to change is we became less restrictive in our policy so we wouldn't get in trouble with regulators. We had 3 separate COVID-focused surveys. We had the first one in July, we had no deficiencies. The next one in September, we had the goggles. And then we had one in October with no deficiencies as well. There definitely is a need for enforcement and regulation. It's imperative for the industry and protection of elders, because you do have, not every company is like ACC, kind of is mission-based and is driven for quality. You do have care centers that really do need regulation and need visit from state auditors. And we want that because ultimately they're helping us provide better care. They just need to change the focus and the prism so it's not always from a punitive model. Next slide, please. So transitioning into a life with COVID. Pre-COVID, St. Elizabeth's was the center of our campus life. We're on the Jenkins Memorial Campus. We are attached to Joachim and DePaul on one side, which are subsidized senior housing, and on the other side, we're attached to Charities Assisted Living. We are very lucky that we have the chapel inside our facility. We have a beautiful 2-story chapel, which we hold mass every day. So everybody from campus would filter into the facility, and then they would spend time in the facility. We have a canteen for lunch. They would go downstairs, they would eat lunch. They would just spend time with the elders. They'd get involved in activities. It was really the place to be on campus. And we always had families. We're the type of facilities where we had families come at 7 in the morning and leave at 7 at night. Another aspect of culture change in St. Elizabeth was that we had 24-hour visitation. So there's always somebody in, and a good care center like ours, we love our families because they only help us and provide better care for our elders. With COVID, we were one of the first facilities to stop non-staff entry in March. There was a huge scramble for PPE. We got really creative. There were some distilleries in West Virginia making hand sanitizer and moonshine, but they just brought hand sanitizer. And so we got really creative because what we were finding was the stuff that was issued by the city and state, they were either not healthcare grade, it would say right on there, not for use in healthcare, or it was like we got gowns that were basically blue ponchos that were unusable. So we got really creative, and we were very lucky because we're part of ACC that we were able to use our buying power to secure PPE. So we were one of the few facilities that we have never had a PPE shortage, and we're really grateful for that. The other huge impact of COVID obviously was with staff. We lost 111 employees since March. Now that's a lot. So just break that down a little bit. Part of that was at the beginning of the pandemic, we weren't allowing people to work in multiple nursing facilities. GNAs, who are geriatric nursing assistants, are the bulk of our workforce. They're the ones who are hands-on with the residents and elders every day, getting in there and being their frontline caregiver. So they typically have 2 jobs. Nationally, there's a turnover rate about 40% for GNAs. Our average wage is $16.43, so it's pretty high. The average wage in the national average wage is close to minimum wage in each state. So we pay a lot higher, so we were able to retain more, but people had to choose between which facilities they were working in because they weren't allowed to work in 2 facilities. We lost, once the school shut down, we have a lot of single mothers that work with us. They had to stop. They don't have great support systems in their neighborhoods, so they had to be with their kids. And then some people were fear. You know, you got to remember back in March, we were just told it affects old people. That's it. We didn't know anything, right? We said if you're elderly, you're worried. If you're young, don't worry about it. Well, that changed quickly, and there was so much misinformation and fear that we lost staff to that as well. We spent a lot of time educating people about what is this disease. We reminded them that we have faced flu and SARS and other pandemics before, and we'll be okay. So this was definitely a huge impact on our facility. Next slide, please. The next thing that we really have to look at is the impact on our elders. And of any population, I think nursing home elders really got hit the hardest. The first thing was suspension of their rights. Just because you're in a care center doesn't mean you don't have rights. You have lots of rights. You have a right to choose, and you have a right to visitors, and you have a right to go outside, and you have rights. You're allowed to be a person. And all of that was suspended. Health department regulation was elders have to stay in their rooms, even with the door closed. Creating just social isolation. In our facility, for those of you who have been there, on different floors, we have little groups of people that hang out. You know, on the third floor, we have our long-term elders who have been with each other for a long time. There's a group of friends. They all come out, they hang out, they play cards together. They're each other's support system. And we had to stop that, and that was really tough. No group activities, no group meals. Again, these are all the social things that people have to look forward to in a day. And we had to tell them, no, I'm sorry, for your protection, you have to stay in the room. So we have seen a pretty large decline in some of those people. And it's been tough to watch. But our facility really adapted and adapted to the new normal, as we're calling it. Staff became the elders' family. Everybody adopted a resident. Everyone got an elder that was theirs. Administrative staff got groups of rooms that they had to go to every day and spend time. And we said, it's okay if you don't finish that work, go do this. We really kind of retooled, we refocused. Everyone from housekeepers up to myself got an adopted buddy. Staff were doing hair and nails and shaving and just spending time and being the friends. We use technology, obviously, iPads and FaceTime with families, window visits. We created a new meal service program where, again, all staff is involved, lunchtime, dinner time, getting to residents' rooms, hanging out with them, spending time with them. The activity program itself, Life Enrichment, had to retool. Instead of focusing on group activities, they had to figure out what they could do in the rooms. And because our care center is so unique, we have everything from a dementia unit to short term and everything in between. They really had to come up with very creative ways. We started national celebrations like National Chocolate Day, National Strawberry Pie Day, National Coffee Day, which is the one I missed. Isn't that terrible? So you created all these wonderful things for people to just have something to look forward to and to have shared experiences and to kind of build that staff morale up, build the residents back up. And then what's really unique and special about us is we have pastoral care. We have a great team. We have Father Ray, who's on campus. We have Carol and Annie, who are just full of love and compassion, and they're making sure that they're always advocating for people and spending time with people and really getting out to their rooms. Next slide, please. So the biggest challenge for us was keeping up with new healthcare guidance. It seemed like every day they were coming up with something new in the morning and in the evening, and you would spend the first half of the morning trying to figure it out, and by the afternoon it would change again. Obviously, the goal was to protect the elders and in nursing facilities. Again, a lot of it was with the preconceived notion that skilled care centers weren't doing enough to protect their elders, right? In the beginning of the pandemic, you heard of facilities in Washington. And really, if you would think back to the pandemic, when you heard about it in skilled nursing centers, right? That was the beginning. And you heard of just people everyone's sick, so nobody came to work, right? And it just pounded nursing homes more than other facilities. So if you look on the right-hand side, the blue line is nursing facilities, and the red line is the general population. So one of the challenges that we face as a PR challenge is that in nursing facilities, we were able to test and identify the virus because we had access to labs, where the general population did not. So the testing in facilities happened way before it happened in general population. So you can see that blue line, the cases were really high, and then they plummeted back down, and now they're in line with general population. Once testing became widespread, we realized it's actually everywhere and not just in nursing facilities. A lot of the guidance they would issue would not be practical. I remember a call with the Maryland Department of Health where they told us the recommendation is to do care twice a day, once in the morning, once in the evening. We were that just proved that maybe they weren't as familiar with a skilled nursing center as they needed to be. That's something you might be able to do in a hospital setting, but in our setting, it's impractical, illogical, and dangerous. Now, the governor issued a lot of directives that seemed to catch the Department of Health by surprise. It caught us by surprise, and then we would reach out to our representatives at State Health or City Health, and they would say, we're figuring it out, we'll get back to you. One of that was testing, one of that was the reopening of nursing facilities, and it was very a top-down approach. Leading Age, which is our advocacy group, did a tremendous amount to work with the administration on kind of figuring out what they meant and to get us clear guidance. So it was definitely a huge challenge for us. But the main thing is that we have to remember is because it was a pandemic, everyone was scrambling, and now we have really clear lines of communication, and we built that system with the health department. And so in the beginning where it was very chaotic, now we've kind of worked out the kinks, and we have a great state epidemiologist. Her name is Emily Luckman. If we send her an email, we get a response within an hour. So we definitely feel the support now, and we're really excited to have that relationship. Next slide, please. So the biggest challenge, aside from healthcare regulations, is the financial impacts to the facility. Again, we're a head in the bed type of payment model. So this year, we are projecting a $1.6 million loss, and that was the good number that we came to. It took us a while, and that was based on certain assumptions. Obviously, testing costs, when the governor made his mandate, it pushed a huge cost onto the facility. So our staff testing cost from March to September was $155,000. Resident testing is mainly covered by insurance. For those who don't have that insurance, it's cost us about $18,000. And then PPE costs and kind of other ancillary costs related to the pandemic focus is about $700,000. So remember, our profit margin is about $70 to $90 a day per patient per day. So this flips that on the head. So it's mainly driven by occupancy. You can see on the right-hand side, on the top is kind of the national occupancy rates in skilled nursing. You can guess 2020 is that sharp decline. And then on the bottom is St. E's, you see a steady decline. We have had to set aside rooms for a COVID unit in the event that we get a case. We need to have a dedicated space. We can no longer put 2 admissions in the same room. They need to be isolated. So at that, we are already at a disadvantage because that makes our max capacity from 162 to 130. So we're already losing out. And then because people have really lost their faith in the healthcare system and they're delaying care, they're not going to the hospital, and so they're not coming to us. Any elective surgery that could be put off is being put off. Anything that, if someone falls, they want to go home. They want home health. They don't want to come to a facility. And then the biggest piece which is still unknown regarding financial impact is liability. There hasn't been a national liability amnesty, if you will, immunity. We have received lawsuits already regarding COVID and COVID care. So that's kind of the big advocacy where we need our advocates to go out and say, hey, if a facility like ours that's had 3 COVID inspections and had no issues in those inspections, why are we held responsible for a global pandemic? And then the other piece is our insurance carrier no longer covers communicable diseases. So it's a full risk and liability to us. Next slide, please. So after all that, the real focus on St. E's always is for the future. We just kind of take each day at a time, but we always want to plan for what's next. So obviously we are dependent on people's faith in the healthcare system. We need people to trust the healthcare system and to be able to venture to the hospitals and then come to us for short-term or long-term care. We need to stay ahead of the competition. We're planning for the refurbishment, obviously. Our centennial is coming up. We're excited. We're exploring options on becoming a specialty-focused care. So are we going to have a CHF program, a joint replacement program? What is going to make us unique And then we are really trying to explore our relationships as a Catholic provider and creating intentional communities. We do know that there are large orders that are consolidating. They are starting to close down facilities. So we want to be that facility where if the order decides that they're no longer taking care of nuns or they're no longer taking care of priests in their setting, on their campus, that they should come to us. So we've already started some discussions with some folks and we'll see how that plays out. And we also want to really focus on our parishes and to figure out when someone opens that bulletin, they're thinking about us. If they need a Catholic provider for nursing, they're thinking about us. And then obviously we are expanding our relationships with the acute hospitals and joining continuum of care, because that's the healthcare network is trying to make closed loops where you need to be in that care model with that hospital. Otherwise, they're not going to send you folks. Next slide, please. So now it's my time to brag. I'm really excited about it. Get ready. You know, the thing that makes us really special and unique is we are part of Catholic Charities. I got 2 different offers when I was looking for becoming an administrator again. One was from Catholic Charities, one was from another organization. You guys know how that played out. So the reason I chose Catholic Charities over the other provider was that in my conversations with my division director, she told me to focus on quality and focus on the mission and enhancing people's lives and making it better, and everything else will fall into place. And that really is my philosophy of care. I was speaking to someone who is looking to become an administrator, and I said, there are 2 types of administrators. Someone who walks by garbage and picks it up and throws it away, or you're the person that calls the janitor over and says, pick up the garbage, right? And those are 2 very different facilities. Those 2 people run very different facilities. I'm come on, let's get the trash and throw it away, and then let's build something. You know, mealtime is my favorite time. And what that does is it motivates the staff and energizes the staff, that they know I'm not going to ask them to do something that is outside what I'm legally allowed to do. There are things, obviously, I can't give medications and whatnot because I'm not a licensed nurse. But anything that I can do, I will do. The big joke in the kitchen is that I'll start cooking. And Baroni is my dietary supervisor. She makes fun of me because every time she has a call off, I said, is it my turn to wash dishes? And then she says, no, I have. So one day I'm actually going to wash dishes and I'm going to be very excited. The other good news is Newsweek named us one of the top 15 nursing facilities in Maryland and the top 400 facilities in the country. So we're really, really stoked about that. The next thing is that we became a 5-star facility this week. We're so excited. Most of my staff doesn't even know because I was waiting for someone else to come off quarantine, but now I'm on quarantine. So I don't know how I'm going to tell them, but I'm super excited. We've worked really hard. And now we're a 5-star CMS rated facility. CMS is the regulatory body, which means we're the top of the top. And our CMS annual surveys are always good. And the Maryland Healthcare Commission always does surveys every year. And they send it out to folks who used to live with you and who got care with you. And 89% responded that they would recommend or probably recommend St. E's as opposed to 78 in the statewide average. And then we got an overall rating of 8.2 out of 10, which the average statewide is 7.6. So we're really excited with those metrics. We're excited to be part of ACC. We have an amazing staff. We really just are focused on the elders and our staff and building them up and building the elders up. And I'm done bragging. I could keep going, but I'm done bragging. So thank you very much for letting me share some time with you guys today. Next slide. Thank you very much.
Awesome.
Well, Zachary, thank you so much for taking the time to do this. I think before I open it up for questions, I just want to give you a little bit more of a chance to revel in the good work that you've done. You know, this has been for everybody, regardless of whether within Catholic Charities, whether in community services, senior services, family services. This has been a confusing and trying time, exhausting in a lot of ways, and probably more so for you and your division than we'd like to acknowledge in certain cases. But what I think you did today, and what should give both our donors and our staff members kind of affirmation here is you just displayed a degree of kind of competence and excellence that we want to continue to put forth as an organization. So kudos for all your good work, and thank you for taking the time. With that, I'd like to open it up for questions, should anybody have any, please.
They're
Well, I'll
stunned.
start.
They're just
Oh,
stunned
sorry.
by me. It's fine. It's fine.
Well, Zachary, I'll start real quickly. You mentioned going back to the beginning of the pandemic when we talked about, and there's still been this kind of nagging idea that this is only something that affects the elderly, right? And that's almost an excuse to not take it as seriously because these people are sick or elderly, et cetera, already in certain cases, it is what it is. As an institution that obviously takes the sanctity of life very seriously, I'd be interested in kind of your thoughts on that and how that's kind of informed your work on a day-to-day basis along with that of your staff.
The hard part is since we're in the healthcare field and we unfortunately experienced loss. We lost elders to the pandemic. So our staff is acutely aware that this pandemic does kill people. And we lost a wide range of elders, folks who were really healthy, that really just needed assistance with daily activities of daily living, which is what we focus on. Maybe they couldn't transfer as well because they had an injury. We lost a wide spectrum. And I think one of the things that's unique about Maryland is Governor Hogan came out very early before it was a political issue and said, put on a mask. And so because he did that and because we had great leadership on the state level, you don't find it so much in Maryland where when you go out, people aren't wearing masks. For the most part, when you go into a store, everybody's wearing masks. Every store requires it. You've heard of those people getting into fights. I'm not wearing my mask, and then the store kicks them out. So I think in Maryland, most people understand that it's a real thing because it happened before it was political. Our staff understands because we do weekly testing, and every week we find one staff member positive. One person, we've gone, knock on wood, we've gone a long time without an elder being positive. We were thrown back into weekly testing due to a provider, a doctor, tested positive at another facility, and that threw us into an outbreak status. And so we had to start weekly testing again. Now every facility, because the positivity rate has gone above 5%, has to test. But I was speaking to other friends who are nursing home administrators. They're just finding one positive person here, one positive person here. So I feel like in Maryland, people really understand the seriousness of the situation.
Zach, how do you see the industry changing? Rub your crystal ball and things that we've had to do because of COVID that will continue post-COVID.
I think what's going to continue post-COVID is low occupancy rates for a couple years. I think that people are going to have kind of a PTSD regarding skilled nursing facilities. I think a lot of people are going to switch to telemedicine as a stopgap measure, and that's going to increase. On our side, we love it because it's less transportation costs, providers, and it gives our elders direct access, and we don't have to send someone out and make it a whole day trip just to see their doctor for 5 minutes. We actually get quality time, and the nurse is able to be there with the elder and explain to the provider what's going on. Where before we would just send the elder out with a guy, like an assistant, who doesn't really know what's going on clinically with that person. So now we can have an RN there with them. So that's actually a plus. But I think the big change and the big shift is going to be low occupancy for a while.
Well, does anybody else have any follow-up questions for Zachary here? He's been very generous with his time, and I want to make sure that we get him back to his day job sooner than later.
To email.
Exactly. I just want to again commend you and the team. 5 stars is awesome, and
Thank you.
And in this environment, the Newsweek recognition was one thing, but the 5 stars for the overall quality, which is our philosophy at St. Elizabeth's, is really just a great recognition for your leadership and people that care for those entrusted to us every day. So I can't tell you how excited I am to see that. You should have started with that slide as opposed to
I'm saving the best for last, you know?
But that's great, and thank you so very much.
Thank you.
He's modest. It is this time, this 8.5 months has been trying on all of us and all of our colleagues, but particularly those caring for older folks and those caring for very vulnerable and medically compromised folks. And our colleagues at St. Elizabeth's are truly heroes. So thank you very much.
Thank you.
Amen. Well, again, I want to thank Zachary Richards for taking time today. We echo all of the plaudits that Bill and everybody else has given you today, along with Newsweek. You know, what the heck? That's fantastic. Great work. I want to thank all of our guests, both internal and external, our supporters, our donors, for taking time out of your schedule to join us today. Our next session is going to be Thursday, December 3rd at 3 p.m. And we're going to be discussing immigration with Mikhail Borganos, who's our managing attorney at Esperanza Center, and deals with immigration legal services. So we hope you'll join us then. Should you have any questions, comments, or concerns, feel free to reach out to any of us at any time. And please take care and enjoy the rest of your day. Thanks again.
Thank you so much.
Thank you.
Thank you so much.